Okay, we're going to go ahead and get started. Now, your exam is 1 week from today. Hopefully, you've been studying and you have lots of questions. But anyway, if you have any questions, if it's just a single short question, feel free to email me with your question, and I'll try and get back to you as quick as I can. Otherwise, if you need to sit and discuss, get in touch with me by email. We'll arrange an office hours or something along that line. So if you have any further questions, we can do that. For the exam, obviously reviewing all the lectures is going to be your primary source. I had also put an article on COPD on Blackboard. It would be to your advantage to go ahead and read that. It helps give a nice current overview of a variety of different things when we talk about respiratory disease, all the way, and includes even some tissue engineering, artificial development of lung tissue, etc. So it really gives you a nice overview of the science of today as well as the medicine of today, where it's going and what they're targeting. So it's a very good article. I used to ask a question from this on the exam. I'm not going to this time, but it would be good for you to go ahead and read this. It is very helpful, as well as, of course, reviewing the book to give you more background of the things that we covered in lecture. However, all exam questions will primarily come from the lectures, nothing that we haven't covered, but the book does certainly support and give you a better understanding. Now, today we're going to be talking about diseases and environmental effects on respiration. For the most part, this is mostly a review of things that we've already discussed in reference to different environmental effects. Somebody's phone. I thought it was mine, but I don't even have mine with me. So environmental effects. So a lot of this stuff is stuff we already covered. So this is going to be kind of review, and is what we're going to do on Thursday is we're going to cover and go over the exam. So if you want to look at that practice exam, we can go over that practice exam from start to finish, or we can go over any other questions that you might have from the lecture material, etc. So on Thursday, come prepared with questions, as well as we'll continue review by going over the practice exam. We can go over each and every question if you like, or skip around, whatever your preference is. On that note, we're going to go ahead and get started. First of all, when we were talking about overall anatomy of the lung structure, it's important to understand how these structures come into play when we're talking about various lung diseases and how that can be affected. So first of all, we were looking at the general overall structure. First of all, that the pulmonary artery brings deoxygenated blood into the lungs. And it's also important to remember that this deoxygenated blood that comes into pulmonary arteries, being it's deoxygenated, it's not the best source of blood to supply oxygen to the tissues of the lung. So as we had mentioned before, it's the bronchial arteries that bring in and support the tissue of the lung primarily. So that's oxygenated blood, and that comes in. So there's two circulations within the lung: the pulmonary vasculature, which we've talked about extensively, comes down to the pulmonary alveolar capillaries. Those are just purely to oxygenate blood, gas exchange. The bronchial circulation is what actually supports the tissues of the lung. Make sure you understand that difference. As well, we talked a lot about the vasculature in of itself, and how the surface area of the pulmonary vasculature in the capillary beds needs to match closely our surface area for gas exchange in the epithelium. So if we lose capillary surface, then we're going to lose the ability for gas exchange. Just as well as if we lose alveolar surface, we lose the effectiveness of gas exchange. So both are very important. We talked about the elastic fibers associated with the interstitium, that space between the alveolar surface and the vasculature. This elastic fibers, and as well there's collagen fibers, that if these are very critical for elastic recoil of the lung. So we need these elastic fibers for normal expiration. Remember, expiration is passive. So anything that affects these elastic fibers affects our ability to breathe normally, such as emphysema. Emphysema, primarily caused by smoking. Cigarette smoke causes an upregulation of proteases within the lung that degrades the elastin and collagen and any other extracellular matrix within the lung tissue. And because of that degradation, we lose surface area, we lose elastic fibers, all of which is very important, especially when we refer to emphysema, how we have an increase in compliance. In other words, we can more easily expand the lung because these elastic fibers are no longer binding the alveoli. There's no stretch, but also we lose that recoil. So it's important to understand the elastic recoil, the elastic fibers. We talked a lot, or a little bit, about maintaining fluid within the lung. The lymph system is very important for maintaining that fluid and helps to remove some of the extra fluid from the interstitial space so that we don't have pulmonary edema. It's important to keep the lung fairly dry. Remember, that's why it's a low pressure system relative to the systemic circulation, so that we have a low hydrostatic pressure so we don't push fluid into the interstitium. As well, the lymph keeps that fluid space also dry because that inhibits and slows down gas diffusion. And of course, we talked about the alveoli extensively, how important the surface area is of the alveoli, thickness of the wall of the alveoli, etc. Anything that impinges upon gas exchange. And you can see the interconnectivity between these alveoli that helps for uniform inflation of these alveoli. Even though their radius and diameter or amount of distension may vary at a resting level. Remember, surfactant also plays a role in uniform inflation. So there's a lot of different things that we talked about with regard to physical and anatomical structures. And also in reference to disease, again, chronic obstructive pulmonary diseases, COPD. This is where we have difficulties in impaired gas exchange due to narrowing of the airways. Now, chronic obstructive pulmonary disease primarily is referring to your upper airway as far as restricting the flow of gases into and out of the lung. Chronic bronchitis was one of those examples. In chronic bronchitis, basically due to an excessive mucus production and general inflammation of the entire respiratory tract, that just causes a narrowing of the upper airways. Emphysema is a very complex, complicated disease. Emphysema falls into chronic obstructive pulmonary disease primarily because it does affect the resistance in the airways. You get mucus accumulation in the airways. And also we talked about in emphysema that we may also have an increased resistance during exhalation. Remember, in emphysema, patients have to actively exhale. If you actively exhale, you create a positive pleural pressure every time you exhale, increasing the potential of bronchial constriction due to that positive pleural pressure pressing on those lungs, especially as they decrease their tidal volume. Now remember, in emphysema, don't be confused that they breathe on a much higher FRC, which helps to hold the lungs open, so that helps to compensate this equal pressure point constriction. But with emphysema, the exhalation force is so great that it still overcomes that larger volume to a great extent, and we do get bronchial constriction during exhalation. So hence it comes into a chronic obstructive pulmonary disease and such that we get narrowing of the airways. As well as, of course, we lose surface area for gas exchange, and we don't have near the ability to get appropriate gas exchange for the rest of the tissues. We talked a lot about pulmonary blood flow again, but in this respect, as we mentioned, we talked about the blood pressure. It's a low pressure system that helps prevent pulmonary edema. And the volume, the blood volume within the pulmonary system typically is very low, but it has a high capacitance. In other words, we can increase the volume within the pulmonary blood circulation extensively, say during exercise. So as we increase cardiac output, the lung is able to take that extra blood volume without increasing pulmonary pressure. So it has a high capacitance. In other words, it can stretch very easily with low resistance and maintain a low pressure. Very important when we're talking about pulmonary blood flow. We refer to also congestive heart failure in reference to poor left ventricular function. And this also, how this can lead to blood pooling in the pulmonary circulation, increasing pulmonary pressure, and once again, pulmonary edema. Remember, between left ventricular heart failure can cause pulmonary edema, and the other major cause of pulmonary edema is hypoxia. Primarily due to altitude is one of the more common hypoxic insults that a normal person might be exposed to. And that hypoxia causes pulmonary hypoxic vasoconstriction, in which all the pulmonary vessels constrict, and that constriction increases resistance, therefore increases pressure, also causing pulmonary edema. We also mentioned briefly about another disease of newborns, primary pulmonary hypertension of the newborn, PPHN. This also is an example of pulmonary vascular disease, creating pulmonary hypertension, in which we can also have pulmonary edema in a newborn. So in this case, these babies are born with pulmonary hypertension. The primary cause, once again, is a pregnant woman who takes aspirin during pregnancy. This aspirin causes a premature stricture or narrowing of the ductus arteriosus, which is the shunt that goes around the lungs in utero. So in a fetus, there's very little blood flow going through the lungs because gas exchange occurs in the placenta. So this shunt through the ductus arteriosus, which comes from the pulmonary artery directly to the aorta, bypassing the lungs, if you expose that to aspirin, that will constrict that vessel and now force that blood flow through the lungs, and the lungs respond to that by constriction and also a hyperplasia of the vascular smooth muscle cells. So we get a thickening of the vessel walls, and we get a constriction because the lungs do not want that high blood flow during development. So therefore they try to limit that, but now when that baby's born and they need the blood flow through the lungs, it's already pre-constricted, it's got a hyperplasia of the smooth muscle cells, it's got a thickened wall, so it does not allow very good blood flow at birth. They treat this with some selective pulmonary vasodilators. One of those is sildenafil or even nitric oxide. When we talked also about the anatomy of the upper airway, we talked about the ciliated epithelial cells found in the conducting zone. These ciliated epithelial cells are very critical for maintaining the airway in such that they produce a fluid layer that fills in around the cilia. This fluid layer is caused by chloride channels secreting chloride, and hence then we get sodium and then water movement, and it creates this liquid solution layer. And on top of that, we have a mucus layer. This mucus layer is secreted by the goblet cells. These goblet cells secrete the mucus. It floats to the top of this saline layer and forms this mucus layer. And that's where all the particles, dust particles, bacteria, viruses, anything that you inhale will stick to it. And then this mucus layer is moved up and out of the airways by the cilia action. We mentioned that smoking decreases cilia function dramatically. Therefore, they don't move this mucus layer out very well. So smokers have a tendency to have a cough. This cough helps to move the mucus out, but due to the decreased cilia function from smoking, that's very ineffective. As well, we talked about cystic fibrosis, a genetic disease which affects chloride transport, the chloride channels in the apical layer of the epithelial cells, the ciliated epithelium. Therefore, we don't get this fluid secretion that you see here that surrounds the cilia. And without this fluid layer, this mucus falls down into the cilia, once again slowing down and impeding their motility and ability to move the mucus out. As well, we talked about the importance of humidification of the air, as well as warming it and filtering it as it passes to the alveoli. So all of this is very important for the ciliated epithelial cells in the upper airway. Again, we talked about anatomical structures, the mechanics of breathing. We talked about the muscles associated with inspiration. Inspiration is an active process. We have to activate these muscles to constrict in order to inspire, which is kind of counterintuitive because you think of a constriction as something that would shorten or narrow. But in this case, constriction of the inspiratory muscles causes an increased volume of the thorax, therefore pulling the lungs open and allowing air to flow in. Now, if we were to weaken these muscles with a couple diseases such as myasthenia gravis or polio, both of these diseases weaken these muscles, and therefore we're less able to do effective inspiration. So there are diseases that affect inspiratory muscles. Remember, the diaphragm is responsible for 60 to 75% of the volume change for inspiration, and the rib cage 25 to 40%. So both of these are very important. And remember, it's the external intercostals within the rib cage that help to pull that rib cage open. But it's the mechanics of the rib cage and the diaphragm as we increase the volume of the thorax that allows airflow to move in. And it's this negative pleural pressure that facilitates this action. It's the negative pleural pressure that holds the lung pleura tight to the thoracic pleura, and so this pleural space is usually a negative pressure which holds it fairly tight to the chest wall, so when the chest wall moves out and upward, that it will pull the lung with it, and therefore creating a negative pressure to allow air to flow in from the atmosphere into the lungs. When we talked about airflow, we talked about Poiseuille's law. Poiseuille's law is in reference to the relationship of length of the airway, viscosity of the airway, and the radius of the airway. We'll talk about that in a little bit more specifically. But of course, resistance is very important and the major contributor to airway resistance, or the radius, and that can be controlled by various constrictors or dilators of the bronchioles. We talked about histamine as being a bronchoconstrictor, and CO2 as a bronchodilator. We used an example of someone who's having a panic attack that causes bronchial constriction, and one way to resolve that is have them breathe in a paper bag, because now you've got an accumulation of CO2. The higher CO2 that you breathe in now helps to dilate those airways and ease the breathing. So CO2 is a bronchodilator, and that's very important also when we talked about ventilation perfusion matching, how CO2 helps to regulate the bronchial constriction or the airflow to match the ventilation or perfusion. So if we have good perfusion to a part of our lung, in other words, there's a lot of CO2 coming back to that part of the lung, it helps to dilate the bronchioles and therefore facilitate good airflow to that part of the lung. So good perfusion gives us good ventilation. As well, on that note, we talked about good ventilation, which provides oxygen. That helps to dilate the vasculature. So now if we have good ventilation, it helps to improve perfusion. So good ventilation gives us good perfusion. So they go hand in hand. Likewise, if we decrease ventilation, we decrease perfusion, or if we decrease perfusion, we decrease ventilation. That's ventilation-perfusion matching. Make sure you understand that synergy between the two. As well, when we were talking about this pleural pressure, the importance of this negative pleural pressure to hold the lung tight to that thorax and the diaphragm so that we can expand the lung. What happens if we lose that pleural pressure or that negative pleural pressure? Remember, a pneumothorax can be caused from either outside the lung or outside the chest cavity, or can come from the inside the lung. Because remember, from inside the lung, this will normalize this negative pressure with atmospheric pressure through your airway. So when we lose this negative pleural pressure, remember the normal elastic recoil of the lung is always to collapse, so it goes to a full collapse. And also, not very well shown here, but the rib cage expands because under normal conditions and normal breathing, the rib cage wants to expand. So when we talk about that more specifically, remember the lung always wants to collapse, has an elastic recoil inward, but the rib cage is kind of held in between. Under normal resting ventilation, the rib cage always wants to move out. That's where the elastic recoil of the rib cage is. However, if we take in full inspiratory breaths, maximum inspiration, now we exceed this rib cage homeostasis and we expand the rib cage further. Now the recoil of the lung wants to come inward. We diagram that in other instances. Now that's above our normal resting ventilation, so if we're exercising and we're taking in larger tidal volumes, now the rib cage at end inspiration also wants to move inward along with the recoil of the lung. So our force is now in combination as opposed to in opposite directions. And remember, at end expiration, at an FRC, these forces are equal and opposite. That's why when you exhale, you relax all your muscles. These two forces of elastic recoil balance. So the lung wants to move in, rib cage wants to move out, but they're equal and opposite, so they sit motionless. We talked a lot about compliance and elastance. Compliance, the ability of the lung to stretch. This affects the work of breathing. We talked about that in a lot of detail when we talked about various diseases, one being restrictive lung disease. Restrictive lung disease reduces compliance of the lung. And the two examples that we use for restrictive lung disease was fibrotic lung disease. This is where we get inelastic scar tissue in the lung, which prevents the lung from expanding normally or freely. So we have a decreased lung compliance because we have this restriction of this fibrotic fibers in there that are very non-elastic. As well, we talked about respiratory distress syndrome, RDS. This is in premature babies where they do not produce enough surfactant by the type 2 cells. And this lack of surfactant has an increase in, we talk about, or a decrease in compliance in that the surface tension is increased. So we increase surface tension if we lack surfactant. Remember, we refer to surface tension like water. If you want to blow a bubble with just pure water, there's a high surface tension of the water molecules. They don't expand very easily. But if you add a little soap to that, you increase the compliance, you decrease surface tension, so now the water molecules will easily expand. It's the same idea as surfactant in the alveoli. The surfactant allows the alveoli to expand more readily and more easily. So make sure you understand the relationship between these restrictive lung diseases, how both of these decrease compliance. And also we talk about increase in compliance when we refer to emphysema. Once again, this is the degradation of the elastic fibers as well as the collagen fibers. This increases compliance. So if you look on this curve, a pressure-volume relationship, this is our normal compliance in the middle, and you can see that we decrease compliance, or we decrease the slope of this line relative to restrictive lung disease, or we increase compliance or increase the slope when we talk about emphysema. Now, elastance is different than compliance. Elastance is the ability of the lung to recoil back to its resting volume. We talked about elastance in emphysema. In emphysema, we have a decreased elastance due to the loss of the elastic fibers. Therefore, you can stretch it out easily, but it will not recoil very easily. Therefore, we decrease elastance. And in reference to restrictive lung diseases, typically, they do not affect the elastance very much. So if you can expand the lung, or however much you do expand it, it still recoils because the elastic fibers are still present. They are not compromised in the sense that their ability to recoil. So elastance is near normal when we're talking about restrictive lung disease, but much decreased in emphysema. This talks about the law of Laplace, surface tension. So make sure you understand that when we talk about surfactants secreted by the type 2 cells, it helps to normalize the differences in distension of the alveoli at a resting volume. So those that are smaller resting volumes, they have a higher concentration of surfactant, decreases surface tension to a greater extent because of the higher concentration than a large or a more inflated alveoli. So therefore, it takes the same pressure to inflate both of these due to the presence of surfactant. Relative to water, if there was no surfactant, then the larger alveoli would inflate more easily and more readily than the smaller alveoli, and we'd have a very inhomogeneous inflation within our lung if we did not have surfactant. So make sure you understand, the effects of surfactant, how it alters surface tension. By decreasing surface tension, facilitates the inflation of the lung uniformly. And as we previously mentioned about looking at resistance, or Poiseuille's law, we gave some very specific examples of how this Poiseuille's law functions. One was we talked about the length of the air system, normally very constant, not a factor. The different things that affect this, of course, for example, how do we increase the length of our airway? Say if we breathe through a snorkel, okay, breathing through a snorkel increases the length of our airway, increases resistance, but what does it also do to alveolar ventilation? It decreases alveolar ventilation because we increase the dead space. Okay, remember anatomical dead space? Now if we're breathing through a snorkel, we just added to that anatomical dead space. So if we have the same tidal volume, we maintain the same total pulmonary ventilation, but now we've dramatically decreased alveolar ventilation. Make sure you understand the relationships between alveolar ventilation and total pulmonary ventilation and the relationship of dead space ventilation. And remember, when we referred to dead space ventilation, we talked about anatomical dead space, but we also talked about total physiologic dead space, or the inclusion of alveolar dead space. Remember, alveolar dead space is alveoli that are being ventilated but have no blood flow. So that's wasted ventilation. That is similar to anatomical dead space in that respect. It does not get involved in gas exchange. So it's very important to include that also. But in this case, we're increasing anatomical dead space, so that'll decrease ventilation as well. Viscosity of the air. We talked about different ways of affecting viscosity of the air. Humidity was one of the major things that we talked about. If you're out running on a very humid day relative to a non-humid day, it's much more difficult to breathe because of the humidity. And typically you don't notice it too much unless you're exercising, but that does amplify the effect of humidity and the increased resistance. As well, we talked about altitude. So if you go to high altitude, what happens to the viscosity of the air? It decreases. And if it decreases, therefore, there's less resistance. Counter to that, if you were to go to a very high pressure, what does that do to the viscosity of air? Well, it condenses it. Therefore, the viscosity increases, slightly increasing resistance as well. These are minor effects relative to overall resistance, but we did talk a little bit about potential effects of liquid ventilation. Liquid ventilation is something that has been clinically tested and looked at. They use liquid ventilation primarily for the treatment of lung injury. So if you have a severe lung injury in which your lungs are damaged and they need to heal, they want to inflate them minimally so that they're allowed to heal. Because if you constantly stretch the lung open, it's not going to allow it to heal very well. So what they do is they try to rest the lung. Different ways of approaching that. One is using what they call ECMO, extracorporeal membrane oxygenation. That's where they put you on a bypass pump and they take your blood out of your body, run it through a pump, oxygenate it, and then put it back in, therefore bypassing the need for the lungs. And then your lungs can sit rather quiet and heal from whatever injury they were exposed to. Another method is using liquid ventilation. There's a hydrocarbon called perfluorocarbon that they use for liquid ventilation. It's got a high ability to take up oxygen as well as CO2 and allows it for gas exchange. So as you breathe in a little bit of air, it equilibrates quickly with the fluid and therefore is able to move oxygen in and out of the lungs. So there's a liquid perfluorocarbon that facilitates liquid ventilation. And in this sense, they just maintain an airflow over this liquid and you get oxygenation without having to inflate and deflate your lungs very much. So that helps to oxygenate without the use of high ventilatory volumes. Very effective in that sense. So there's a lot of clinical studies that did occur with liquid ventilation. We did a lot of those studies here in Buffalo as well. We talk about diameters of airways, breathing through a straw or a garden hose. So in general, if you breathe through something very narrow, it's going to be high resistance. You breathe through something very large, it's going to be lower resistance. And so if we refer to more so the upper airway, we can have physical obstruction, whether it's mucus or any other physical obstructions within the upper airway that will increase resistance. As well, if we go further down in the respiratory tree where there is no cartilage, now we can have constriction and relaxation of the smooth muscle that surrounds the airways. And so we have bronchoconstriction, typically influenced by the parasympathetic neurons, and they can release histamine, leukotrienes, anything that's a bronchoconstrictor. As well, we can have bronchodilators. These are primarily come from the sympathetic nervous system, such as epinephrine, norepinephrine, and also carbon dioxide, as we mentioned, is a good bronchodilator. Make sure you understand its reference into pulmonary ventilation perfusion matching. So that's a good bronchodilator. So changing the diameter of the airway is very effective and regulates resistance to a great extent. Remember, it's radius to the fourth power. So this is more influential than length and viscosity. So this is our primary regulation of resistance, even though resistance can change through length and viscosity in other minor ways. We've already mentioned, to make sure you understand, the difference between pulmonary and alveolar ventilation. How we breathe affects oxygenation. We gave examples of increasing tidal volumes, increasing respiratory rates, and what the effect is on alveolar ventilation relative to pulmonary ventilation. And as we just mentioned, anatomic dead space typically is your conducting airway under normal conditions. However, if you breathe through a snorkel, you increase this anatomic dead space. And we also talked about alveolar dead space, which in essence is still wasted ventilation and is included in dead space ventilation. So when you calculate alveolar ventilation, that refers primarily to ventilation that goes to the alveoli that's available and involved in gas exchange. So therefore, alveolar dead space also needs to be subtracted from from total pulmonary ventilation to give us alveolar ventilation. Make sure you can do these calculations backwards and forwards depending on which variable we're looking for. Make sure you can calculate either ventilatory rate, tidal volume, dead space volume, and also relative to pulmonary ventilation, relative to alveolar ventilation. This was the examples that we used looking at tidal volumes and ventilatory rates, maintaining a similar total pulmonary ventilation, no matter how we changed our volumes and rates, but the effect on alveolar ventilation. So if you understand those equations that we just talked about very extensively, you see under normal conditions, the alveolar dead space, the dead space, anatomic dead space, remains constant. But if we increase the rate, or decrease rate, it affects our dead space ventilation. And you can see the huge effect on alveolar ventilation. So under normal conditions, we have 4,200. And you can see how we can decrease this dramatically or increase it dramatically. So dead space ventilation is nothing more than the dead space volume times the rate. Okay, so that's what these numbers are. So make sure you understand the relationship between alveolar and total pulmonary ventilation. And extreme examples where we talked about a tidal volume of 150 ml and a rate of 40 breaths per minute. And if we're extremely tachypnic or hyperventilating to a great extent in this sense, you can see what happens to alveolar ventilation. It can actually go to 0. So we can really alter this. And remember, this is a possible ventilatory pattern that you could do sitting right there. You could do this pattern, and you wouldn't be able to do it for long because you would have no alveolar ventilation, and your CO2 would climb very high, your oxygen levels would decrease. Other ventilatory breathing patterns we referred to was hyperventilation and hypoventilation. Make sure you understand the relationship of these relative to alveolar ventilation, but not only relationship to alveolar ventilation, but also what happens to the partial pressure of oxygen and the partial pressure of CO2 in the alveoli and the arterial circulation if we do hyperventilation or hypoventilation. Make sure you know the changes in partial pressure. Remember, if we hyperventilate, that means we're bringing in more oxygen than normal, we're flushing out the CO2, and we're increasing the oxygen. So the partial pressure of oxygen is going to increase, partial pressure of CO2 is going to decrease. And it's just the opposite when we refer to hypoventilation. All right, make sure you understand these effects on oxygenation and removal of CO2. We talk a little bit about apnea when we're talking about ventilatory regulation. Apnea is where you slow down your ventilatory breathing or actually cease breathing. What was an example we did in a disease where we could actually induce apnea from disease? Emphysema. Remember, we talked about in emphysema that you lose the response to CO2 after a long period of time with high CO2s. which patients with emphysema or even chronic bronchitis get. And therefore, their regulatory pattern is primarily controlled by that CO2 level. So now if you don't respond to CO2, you're more likely to respond to low oxygen. But oxygen, the peripheral chemoreceptors respond only to oxygen as it falls below 60 millimeters of mercury. So therefore, we go into apnea. So we have long periods of time where we don't breathe until the oxygen reaches a low enough level that causes us to breathe. So that is one aspect when we refer to apnea and how that's influential in our breathing pattern. This is where we refer to, once again, our alveolar to ventilation and how that refers to peripheral blood flow, capillary blood flow, ventilation, perfusion, matching. So once again, remember, we're only going to be referring to primarily the strong effects here. We're not going to worry about these weak effects. So when we refer to CO2, remember, high CO2 causes a dilation of the bronchioles. Low CO2 causes a constriction of the bronchioles. So therefore, if we have a high CO2, remember, the CO2 comes from the tissue. So if we have good blood flow to the alveoli, that means we're going to have a lot of CO2. So if we have good blood flow, high CO2, we dilate the bronchioles, and we match that with good airflow. Likewise, if we have poor blood flow, say we have a pulmonary embolus, in other words, a blood clot within our lungs, that blood clot decreases the blood flow to that part of the lung, there's going to be very little CO2 getting to the alveoli. Therefore, we're going to have a low partial pressure of CO2, and then we're going to constrict the bronchioles, and now we're going to match poor blood flow with poor airflow. So it's important that as a protective mechanism within our lungs that we're able to do ventilation perfusion matching. Because remember, as we decrease airflow to part of the lung, if we take the same tidal volume, that airflow redistributes to the rest of the lung that is getting good blood flow. So we redistribute. And remember, under normal resting conditions, we don't utilize all of our lung. Remember, we talked about the apical relative to the basal part of our lung at rest, how we have more ventilation and perfusion to the base than we do the apex, primarily due to gravity. But as we exercise or we need to recruit more of our lung, then we open up more of the air space, more of the vascular space to utilize it. So this regulation just does the same thing, but it does that automatically. So therefore, if we're sitting at rest and we have a poorly perfused part of the lung or a poorly ventilated part of the lung, it will redistribute to a part that is not diseased or more effective. So it's very important that this mechanism works under local regional regulation. So remember, likewise, we talked about changes in oxygen. If we hyperventilate, what did we say? We bring in more oxygen. So if we bring in more oxygen, that means if we're seeing a large amount of oxygen in the alveoli, we dilate the pulmonary arterioles, so we have good ventilation. So let's match that with good perfusion. And likewise, if we have poor oxygenation in the alveoli, in other words, if we have a mucus plug in some of our bronchioles where we restrict airflow to some of the alveoli, we're getting poor oxygen to the alveoli. This low oxygen causes the pulmonary vasculature to constrict. So now we have poor ventilation, poor perfusion. Now where this comes into a problem is when we have global decrease in partial pressure of oxygen, such as if we go to altitude. Remember, at altitude, the barometric pressure decreases. The fraction of inspired oxygen is still the same, but therefore we have a decrease in partial pressure of oxygen. And if we have a decrease in partial pressure of oxygen and we expose our entire lung to low oxygen, now all of the pulmonary vasculature or capillary beds constrict. And if that occurs, now we have poor blood flow to the entire lung. We increase the pulmonary vascular resistance, therefore increase the pulmonary vascular pressure, and then we get pulmonary edema. And pulmonary edema decreases oxygen diffusion even more so. So once somebody, typically you've seen it in many of the movies, climbers go into high altitude. Once this starts, and once they have a little bit of hypoxic pulmonary vasoconstriction, it gets worse rapidly. So once it starts to set in, it progresses very quickly because a little bit of hypoxia leads to more hypoxia, especially as you start producing more and more edema, because more and more edema restricts oxygen diffusion more so. Okay? So it's a spiraling situation that just gets worse. And we also referred to that when we talked about asthmatics. Remember, in asthma, people use inhalers, and they use these inhalers very early when they sense any kind of restriction. Because if they don't use it early, the inhaler becomes very ineffective, because once you have bronchial constriction, first of all, it limits airflow. So even if you puff on the inhaler, you can't get it to the bronchioles to cause a dilation. And also, as they constrict, once again, it impedes upon, we get vascular constriction. And once again, that causes further constriction, because if the vasculature constricts, we decrease the CO2, and if we decrease the CO2, we get more bronchial constriction. So in asthmatics, once they get a little bit of constriction, it will also spiral into a lot of constriction. So it's important that asthmatics use their puffers at the very early signs of restriction or bronchial constriction. So we talked about altitude, hypoxia, altered gas mixes. Anything that affects the partial pressure of oxygen, you're going to see some of these responses. Now we'll go ahead and do a couple questions from Top Hat Monocle. So if you want to get ready for those questions, we can do so. Remember, I will give you 2 minutes per question, so you won't get the full 3 minutes, but you'll get 2 minutes, which should be more than sufficient. So our first question. Which enzyme is responsible for the conversion of carbon dioxide to bicarbonate? Remember, we talked about this with regard to transport of CO2. Now remember, these are fairly easy, straightforward questions. The questions on the exam will be a little more testing of your knowledge. So don't think the exam questions will be quite this easy. Give you 1 more minute. Glad to see you're getting quicker at responding. I guess you're all getting used to your new phones, right? Okay. Answer, of course, is carbonic anhydrase. And, of course, everybody got that correct. Almost everybody. So make sure you understand that chemical formula. We talked about it extensively. It's very important for the conversion of CO2 to bicarbonate and transporting it in the plasma of blood. But it's also important when we talked about respiratory regulation in the cerebral spinal fluid, in the central chemoreceptor, that the carbonic anhydrase is responsible for converting the CO2 to carbonic acid and then to bicarbonate and hydrogen ion. And it's the hydrogen ion that activates the central chemoreceptor. So this is very important in both situations. Make sure you know how it comes into play in both of those situations. So our next question, see, we're having so much fun. Which of the following will decrease arterial PO2? Alveolar ventilation, alveolar capillary membrane thickness, airway resistance, all of them. Once again, these questions are a little more simplistic than what you're going to have on the exam. On the exam, you'll be looking more specifically about some of the things that would affect arterial PO2. One more minute. Okay, so everybody's got the right answer submitted. Of course, it was all of the above. So if we decrease arterial PO2, remember arterial PO2 is primarily in equilibrium with alveolar PO2 unless we have something that affects the diffusion or the equilibration of oxygen moving to the vasculature. So if we decrease alveolar ventilation, we decrease partial pressure of oxygen in the alveoli, therefore decrease PO2 in the arterial. Increase alveolar capillary membrane thickness. Here we can have a normal alveolar PO2, but we have a decreased arterial PO2 due to a decrease in diffusion because we increase the distance of diffusion. And as we increase airway resistance, increasing airway resistance will decrease alveolar PO2, therefore decreasing arterial PO2, and hence all of the above. So make sure when you think about these, think about what's affected initially and then subsequently. So make sure you follow this pathway and these mechanisms all the way through, because these questions can vary, and where it comes into effect is going to be important. I could have mentioned which ones affect alveolar PO2, and therefore this would not affect alveolar PO2, but it does affect arterial PO2. So make sure you understand where this comes into play. We have one more question. Which of the following would elicit the greatest response to increase alveolar ventilation? In other words, what's going to cause us to increase alveolar ventilation most? Once again, on the exam, it says to give the best answer. So remember that there may be more than one answer that works, but it says give the best answer. So if something might have a minor effect, that's not going to be as important as something that has a major effect. So make sure you understand that. So which one of these is going to have the greatest response? So this is more similar to what you would see on an exam question. All right, time's up. Get your answers in. Increase in arterial PCO2. All right, we'll walk through this. Well, first let's see what the report is. Okay, so you guys need to brush up on this a little bit. Now, increase in arterial PO2. If we increase our arterial PO2, what's that going to do to our ventilation? If anything, decrease it, not increase it. Okay? So that one's a gimme. All right? So 18% of you or 41 of you really need to relook at that. Increase the arterial PCO2. Remember, we said CO2 is our greatest regulatory mechanism in controlling breath to breath. So CO2 is very important, and the fact that we say arterial CO2, so it's arterial CO2 that goes to the central chemoreceptors, and then the CO2 diffuses into the cerebrospinal fluid, converted to bicarbonate hydrogen ion. That hydrogen ion affects the receptor. But that all initiates with a high arterial CO2. Increase in arterial pH. Now, if we increase the pH, that means we make it more basic. Okay? If anything, that's going to decrease ventilation. All right? So that will decrease ventilation. Increase in arterial hydrogen ion. Now, that means it's more acidic. pH is decreasing. That will have some effect on the peripheral chemoreceptors. Remember, peripheral chemoreceptors are affected by decreased oxygen, increase in hydrogen ion, or decrease in pH. Oxygen being the primary effector in the peripheral chemoreceptors. So this plays a very small effect in the peripheral chemoreceptors. However, if we talk about the central chemoreceptors, what does arterial hydrogen ion do to affect the central chemoreceptor? Nothing. Remember, hydrogen ion is impermeable to the blood-brain barrier. Therefore, hydrogen ion does not affect the central chemoreceptor and only has a slight effect on the peripheral chemoreceptor. Therefore, this is our best answer, okay? So remember, on the exam, pick the best answer. Any questions concerning this regulation? All right. Make sure some of you look at that a little more closely. So now we continue. Remember, normal lung. As we breathe, we typically have a normal alveolar PO2. And we have a normal arterial PO2. However, PO2 in the alveoli is determined by atmospheric pressure and also alveolar ventilation. So even if we have a normal lung, we can alter alveolar PO2 and we can alter arterial PO2 very easily. Atmospheric pressure, not necessarily easily, but if you want to go climb a mountain, you can do that. Go scuba diving. But alveolar ventilation, you can control that just sitting there. Okay, so this, by controlling and altering your alveolar ventilation, we can alter alveolar PO2 and our arterial PO2. Okay, so remember, even if we have a normal lung, we can have alterations here. Now in emphysema, we talked about how this is a destruction of the alveoli, which reduces surface area for gas exchange. It also reduces pulmonary capillary surface area, because if there's no alveolar surface area, there's no capillaries in that space. So we decrease gas exchange dramatically by reducing surface area in emphysema. Now, in this situation, depending on the extent of the emphysema, we can have a normal or low PO2. It can still be normal if emphysema is not so bad that you can compensate. And how do they compensate for emphysema? They breathe at a higher lung volume to help facilitate a normal tidal volume. They can breathe faster. Okay, so, and also they use forced exhalations to help move that tidal volume. So if, depending on the severity of emphysema, you can compensate, and sometimes you can compensate enough to keep a normal alveolar PO2. But typically emphysema just gets worse and worse as it progresses, and eventually it will become low. No matter what compensation they do, they will not be able to maintain a normal PO2 unless they're on supplemental oxygen. So either way, even if alveolar PO2 is normal, because of decreased gas diffusion, we're going to have a low arterial PO2. Okay, so compensation can only go so far in helping to maintain an arterial PO2. So typically, in emphysema, even milder cases, this is still going to be low arterial PO2, and that's the most important because that's what gets oxygen to our tissues. So the reduced surface area, creating hypoxia, hypercarbia. Hypercarbia means high CO2. Typically, if we have hypoxia, we have hypercarbia. And we're talking about the arterial circulation. So the arterial circulation is low oxygen, but the CO2 is also going to increase because of poor gas diffusion. Now, in this case, we might even be able to have a normal CO2 if this severity is not so bad. Because remember, CO2 is more highly diffusible than oxygen. So in this case, oxygen is going to be low. CO2 could be increasing, but depending on how poorly the diffusion is, it may equilibrate. Okay, so make sure you understand all the concepts of oxygen and CO2, how the alveolar partial pressures of these are going to be affected, as well as the arterial partial pressures. Okay, so this gives us a good example of looking at gas diffusion, equilibration and diffusion of oxygen and CO2, the differential between those. All right, so make sure you understand those. And these are good review slides so that you can think through each step. Now, when we refer to fibrotic lung disease, we refer to a thickened alveolar membrane. Now, this thickened alveolar membrane slows gas diffusion because it increases the distance of gas exchange. Also, we have a loss of lung compliance, and that could decrease alveolar ventilation. So in this case, we say once again we could have a normal to low alveolar ventilation depending on the severity of the disease. So if we have mild disease, we can use more inspiratory effort to expand the alveoli to get a normal tidal volume in there. So if we can compensate, then our PO2 in the alveoli will be normal. But if we can't fully compensate, it will be low due to low tidal volumes because of the poor compliance. As well, we will have a low arterial oxygen because of decreased gas diffusion. We've talked about pulmonary edema, and remember we talked about pulmonary edema. This can result from left ventricular heart failure. It can result from high altitude hypoxic pulmonary vasoconstriction. So whatever the cause of pulmonary edema, that's where we get an increase in fluid in the interstitial space, increasing the diffusion distance. So in this case, we can have a normal alveolar PO2 only if our atmospheric oxygen is the same. So if we have pulmonary edema due to altitude, well, in that case, our alveolar PO2 may be decreased. But if we have pulmonary edema due to left ventricular heart failure, well, then we certainly can have a normal alveolar PO2. So even in this instance, depending on the source of pulmonary edema, this can be altered. But we know we're definitely going to decrease arterial PO2 because of the increased diffusion distance. And once again, depending on how severe this pulmonary edema is, CO2 may equilibrate or it may not. Remember, CO2 can move much more quickly and readily than oxygen. So even though oxygen's low, we still may be able to get a normal CO2 diffusion across here, depending on the severity. So always keep that in mind. We talked about asthma. When we refer to asthma, this primarily refers to increased airway resistance due to bronchial constriction. Now, this is going to decrease total ventilation as well as alveolar ventilation. So in this case, we have a low alveolar PO2 just because we can't move enough gas in, and we're going to have a low arterial oxygen. So what's going to happen to the partial pressure of CO2 in this case? Okay, if we have poor gas exchange, CO2 is going to increase in the alveoli, and it's going to increase in the arterial circulation because it's got nowhere to go, or it's limited in exchange. So CO2 will increase in alveoli and arterial in this case. So also, if you look at this long term, remember low oxygen causes a vasoconstriction. So if we have poor alveolar oxygen, now this is going to vasoconstrict. So if this vasoconstricts, now we have a low CO2, and then the low CO2 causes a further bronchial constriction. That's the reason we talked that asthmatics need to use that inhaler very quickly, because this is a very rapid cycle that occurs. So we talked about a variety of different aspects, so make sure when you're leaving looking at a normal lung, talk to yourself, think about what can affect alveolar oxygen, alveolar CO2, arterial oxygen, arterial CO2. Okay? Hyperventilation, hypoventilation will both affect, even in a normal lung. So make sure you understand what happens in a normal lung, also what can happen in emphysema, fibrotic lung disease, pulmonary edema, asthma. We talked a lot about hemoglobin saturation, two alpha chains, two beta chains. Remember, in a fetus, we have two gamma chains. Gamma chains help or increase the affinity or binding of oxygen to hemoglobin because of the hypoxic environment of a fetus. Also, high altitude causes chronic hypoxia, resulting in increased production of erythropoietin, increasing the number of red blood cells and the amount of hemoglobin. Remember, increasing or decreasing hemoglobin and red blood cells has no effect on the partial pressure of oxygen, but has a huge effect on oxygen content. Make sure you know the difference between content and partial pressure. Oxygen hemoglobin dissociation curves. We talked about shifting the curve to the left, shifting the curve to the right. We shift the curve to the right, it means we decrease the affinity of hemoglobin for oxygen. Therefore, oxygen comes off more readily and is more available for use in the tissues. We look at the top end of these curves, we have very little difference. So if we shift the curve to the left or to the right, we're still at 95% saturation, 95 to 100%. Very little effect on the alveolar end of this, but a huge effect when we talk about the tissue level. So at the tissue level, you can see the difference in saturation as we shift this curve left and right. Okay, so it's very important when we get to the tissues. That's why we talk about an oxygen dissociation curve. How does it dissociate from the hemoglobin? The different effects, we talked about pH, we talked about temperature, we talked about CO2. Make sure you know, primarily, if we increase metabolism, we increase all three of these, or actually decrease pH. So all three of these move to the right if we increase metabolism. These are examples of other things that shift the curve to the right or to the left. Make sure you know the relationship of shifting the curve right, shifting the curve left. Also, we mentioned P50. P50 is the partial pressure at which the hemoglobin's 50% saturated. So if we look at the normal curve on this one here, P50 would be 50% saturated. You come across to whatever curve we're referring to, and then you come down and look at the partial pressure. So in this case, the partial pressure would be about 28. So that'd be the P50 of this curve. Make sure you know what the P50 means. If we increase the P50, that means we decrease the affinity of oxygen for hemoglobin, and we shift the curve to the right. Make sure you know that. Also, 2,3-diphosphoglycerate will shift the curve right and left, and that's pretty much produced in the red blood cells. And if we have a chronic hypoxia, we get more 2,3-DPG, shifting the curve to the right, making oxygen more available. This can happen in high altitude as well as anemia. That can cause a shift of the curve right-left or the regulation of 2,3-DPG. This here is an excellent review of looking at many things in which we referred to. So when we talk about ventilation, the most important thing is getting oxygen to the tissues. So if we look at total arterial oxygen content as the end result, we look at oxygen dissolved in plasma, which gives us the partial pressure of oxygen in the arterial blood. These are all the different things that can influence the partial pressure of oxygen in blood. Composition of inspired air, whether it's hypoxia, altitude, alveolar ventilation, how we regulate alveolar ventilation, tidal volume, lung compliance, rate of breathing, airway resistance, all these affect alveolar ventilation. Oxygen diffusion between the alveoli and the blood, remember Fick's law. Surface area, diffusion distance, interstitial fluid, membrane thickness, as well as perfusion of alveoli. If we have a pulmonary emboli, which we have a blood clot in part of the lung, therefore there's no blood flow, that's going to decrease the total amount of oxygen we can get there, because then that turns into alveolar dead space. Also, with respect to arterial oxygen content, we talk about oxygen bound to hemoglobin. That's relative to the percent saturation of hemoglobin. In other words, we need to saturate the hemoglobin molecules with oxygen. Remember, you can have 4 oxygens per hemoglobin. 3 oxygens is 75% saturated. 2 oxygens, 50% saturated. Different things that can affect this, shifting the curve to the right or to the left. CO2, pH, temperature, 2,3-DPG, as well as total number of binding sites on the hemoglobin can be affected by hemoglobin content per cell or the number of red blood cells that have hemoglobin in them. And we talked about blood doping using your erythropoietin or packed red blood cells, putting them back into your circulation so you can increase the carrying capacity, increasing the amount of hemoglobin, all with respect. And these are some different things that can cause changes and alterations in total oxygen content. Blood loss means we have less hemoglobin. Anemia means we have poor blood production, therefore we have a decrease in hemoglobin. And of various respiratory diseases, which can affect primarily this side, but there's other respiratory diseases such as even carbon monoxide poisoning affects the number of oxygens binding to hemoglobin. So that also comes into play when we're talking about total arterial oxygen content. Of course, we talked about regulation more recently. CO2 is a primary regulator of respiration in the central chemoreceptors, oxygen, pH, and oxygen in the peripheral chemoreceptors, but oxygen is the primary regulator in the peripheral chemoreceptors. Remember, all of these inputs come into the central pattern generator in the medulla, the pons, but it's the responsibility of the dorsal respiratory group to control inspiratory muscles, ventral respiratory group to control expiratory muscles. Okay, so make sure you understand these interactions, and if you want, you can just look at these things over here. We aren't going to talk about these specifically, but just make sure you understand the mechanism and the pattern or feedback mechanism that we've discussed. And finally, we get down to the last couple things. We talked about diving. Remember when we talked about diving at depth, 33 feet underwater is equivalent to 1 atmosphere. All right, so 1 atmosphere is equivalent to 33 feet underwater. So if we're at sea level, we go 33 feet underwater, we're now at 2 atmospheres. That controls barometric pressure, therefore controls partial pressures of the oxygens and gases that we breathe. So if you're breathing a normal air mixture, 33 feet underwater, you just doubled the partial pressure of oxygen that's getting to the alveoli. We talked about, of course, a variety of different things: atmospheric pressure, airway resistance. In this case, airway resistance because we're breathing through a long tube. This increases resistance, increased dead space. Once again, it's anatomical dead space. Increased viscosity. If you're at 33 feet of depth, we just increase the viscosity of the air because now it's at higher pressure. Gas molecules are closer together. Therefore, we have an increased viscosity. All of these things occur with diving. And of course, snorkeling, some of the similar things, as well as we talk about parasympathetic and breath holding. What happens there to your regulation of ventilation? So we talked about all of those aspects, as well as we talked about high altitude. Remember, atmospheric pressure, barometric pressure is lower, therefore the partial pressure of the gases are lower. Hypoxia, pulmonary edema, this is high altitude pulmonary edema, causing pulmonary arterial vasoconstriction. And however, a response to long-term hypoxia, we increase the number of red blood cells, increase the amount of hemoglobin. And your typical response to hypoxia is to hyperventilate. If you hyperventilate, you create an alkalosis and an increase in pH. So don't forget that there are responses to a variety of different environmental conditions, which also alter our regulatory controls. Any questions? Have all your questions ready for Thursday. We'll continue on reviewing at that point.
I just had a question on the slide with the diving. You said that it's 1 atmosphere equals 33 feet, but then under sea level it's 2 atmospheres?
Well, because remember, at sea level, you're at 1 atmosphere.
Oh, okay.
Don't forget to add that in.
Okay.
And that's why.
I just take the highest one.
Oh, the highest
Yeah,
one.
yeah,
you
yeah.
take.
Yeah, so you should always get 10 out of 10, right?
Right.
Okay.
Oh, you can leave it all open. This is easy. You can just walk away.
What are you teaching? This is pharmacology, though. Yeah, no, you're. I was kept. You're in the wrong room. Okay. No, don't worry.